So
Wonderful.
I'd like to thank you for asking me to do this series of 3 webinars in association with the British Pakistani Ophthalmological Society. And Dr. Adnan, thank you so much for asking me. And for all of you who have given your time today, I hope that you find today's webinar useful. So this is the second part. Last week, we met to discuss how to get the most out of your ophthalmology training, especially if you are a doctor in Pakistan and what part of your goals is to come to the UK to do some of your training or all of your training. And we spent time discussing, if we could have the next slide, please. We'll just summarize what we talked about last week. And then the opportunity for the audience, those of you who did attend last week, if you have any questions or comments. So in session 1, we talked about what is your portfolio of evidence. As you are training in ophthalmology, how can you gather objective evidence to put in your portfolio that shows that you have achieved the ophthalmology competencies that you need, the learning outcomes that you need to show that you are progressing in your training, and that eventually when you obtain all of the competencies that are listed in the Royal College of Ophthalmology London curriculum, that's 180 learning outcomes which are spread across different categories. For example, patient investigation, patient management, surgical skills, and so on. There were many categories that we discussed. So we talked about the portfolio, we talked about the structure of a CV, and then we talked about job applications and some tips on interviews and filling in the application form, common questions that come up. And we then talked about, once you're in that job, how do you get most out of your time in that training job? So we also talked about what an appraisal is and what a personal development plan is. And then at the end, we summarized by showing how it's all interlinked and how you can start now, regardless of the stage of training that you are at, whether you are very junior, middle, or even senior. Just how will you organize your evidence and your portfolio in a structured way to make it easy for yourself and to get the most out of your time? So for those of you who weren't here last week, a little bit about me. Dr. Adnan invited me because we met at a British Pakistani Ophthalmological Society event where Ijaz Sheikh asked me to chair the session. And we had trainees from Pakistan, and Dr. Adnan Abdul Majid was one of those trainees who presented a case, and then he and I did some coaching afterwards, and that's how we got to know each other and what we do. I realized Dr. Adnan is very passionate about promoting high quality education and training amongst his peer group, so peer-peer support, which is wonderful. And the British Pakistani Ophthalmological Society I came to know when I came to Pakistan for the ICON Medical Retina in Peshawar in 2021. That was organized by Professor Sanaullah Jan, and I met Ijaz Sheikh there, and then we started to work together under the banner of the British Pakistani Ophthalmological Society. And we're all here because we have a link to Pakistan and we want to support each other as a professional ophthalmology group. How can we help each other to collaborate and to focus the needs that trainees have both in the UK and in Pakistan, which seem to center around high quality research, audit work, and communication. So today's webinar is the second in the 3-part series, and we're going to focus on communication. So from last week, I just wanted to open the floor to say, were there any questions, comments, or would anybody like to share their personal experience? It could be that we have a completely fresh audience. And how many people were attending the last webinar? I'm just interested to know. Do you know, Dr. Adnan?
Yes, ma'am. Most of them have.
Yeah.
Yes,
We're
most
here.
of them.
Okay.
Yes, ma'am. Ma'am, I have a question. Can I ask?
Of course.
Ma'am, I have gone through the Royal College of Ophthalmology website, and I have read the learning outcomes.
Yeah.
Especially talking about the portfolio buildup, I wanted to ask, in Royal College, there is a electronic system of recording the portfolio. In case of Pakistani trading, we don't have such an electronic system of recording our portfolio. We usually do have CPSP e-portal, but that is specifically belongs to them. They cannot share it with anybody else. They got for them on self. But I wanted to say, how can we record our portfolio? Should we build our any website or app, or can we record it in a paper-based documentations?
Okay, that's such an excellent question, Dr. Adnan. Can I ask you, the Royal College of Ophthalmology e-portfolio, I believe if you become a member of the Royal College of Ophthalmologists, an international member, that you then can get access. So that's something that we can look at. I'm not 100% certain about that. And also I need to check what are the requirements to be an international member of the Royal College of Ophthalmologists. Do you have to get the FRC Ops first? I know that if you get the FRC Ops, you can definitely be a member, and members have access to the electronic portfolio. The second option is, I did know up until a certain point, they certainly had paper forms. They had PDF documents that you could download and print off. So yes, you could therefore do a paper one. However, I am not 100% certain if they've got rid of those or if they're planning to get rid of the paper, because they want to encourage electronic portfolios only.
Thank you, ma'am.
So the short answer to your question in summary is become a member of the college and you'll get access. Number two is download the paper forms, which I know some people certainly up to 2021 were doing, but now in 2020, I just need to double check. I'll just make a note to see if I can find that out as well.
Okay, ma'am. Thank you.
Okay, well, thank you for that question. I'll move on to the next slide. If anybody in the audience thinks of anything else, please, raise your hand or put the comment in the chat, and Dr. Adnan is moderating and he will put your question forward. If you would like to move on to the next slide, let's talk about what we're going to learn today, inshallah. Okay, so what are the common complaints that arise? And in my, what about the extreme pressure response? I'm going to tell you about this. We as healthcare professionals, all of us, regardless of whether we're working in Pakistan or the UK, are working under high pressure situations, often with, difficult situations, under-resourced, understaffed eye clinics. And so this causes a lot of personal pressure. And how does this affect us in our work? How does that then link to the number of complaints that can arise? And then how do we deal with that? Feedback is so essential. And we're going to talk about how to give feedback and how to receive feedback. The equation for achieving change. This is something that I wish I knew 20 years ago. It would have helped me a lot. And I want to share this with the audience to see if it helps you and maybe it can save some time for you. Preventing negative impact of the complaints process. To some extent, we all have to accept as medical professionals, as surgeons, that it's inevitable that at some point in our career, a patient will not be 100% satisfied with the care that they receive. It is inevitable statistically that we will receive at least one complaint in our career. So it's kind of there is no surgeon who doesn't have a complication, right? It's similar. There's no healthcare professional who won't have a complaint. So let's not treat it like something that devastates us completely. Let's look at it as an opportunity with a growth mindset. And how can we learn to improve so that we don't repeat the same mistake? I think it's devastating if we identify mistakes and don't put any measures in place to prevent that from happening again. That's the devastating thing. Actually, making a mistake that causes a complaint isn't devastating, as long as we use that as a learning opportunity for growth. So if we can have the next slide, this is what we're going to cover today. Thank you. All of this comes from my virtual program. So as I mentioned earlier, I I'm a consultant ophthalmologist. I resigned from the NHS and moved to USA last year. I'm now going to be the clinical development medical director at Novartis in the USA in ophthalmology. So my job will be to, whenever new treatments come out, to be part of the team that gets the FDA and the EMA approval, the licensing. So that's a bit about my background. But since I started training in ophthalmology, which was in 2003, I've always been involved in postgraduate medical education in ophthalmology. And I worked my way up from college tutor for the Royal College of Ophthalmologists to senior examiner to national educational advisor for the exams committee at the college and head of school of ophthalmology for the Yorkshire and Humber training program. And that's why I have a knowledge of the curriculum and the training requirements. I'm also a CSER assessor, and I also work for the GMC on the tests of competence and revalidation panel. So that's just a little bit about me. If we move on to the next slide, please. So what I wish I knew 20 years ago, I want to share this with you right at the beginning, because this is my gift to you, okay? If you ever want to achieve change, you see a situation where change needs to be achieved. What the change results from, first of all, there's these 4 components. D is dissatisfaction with the current status quo. You need to identify that you are not happy with how things are, and you need to raise awareness of that. You then need to have a vision for how you want things to be. You've got to visualize it and say, the current status quo is we are not satisfied. If things carry on like this, the following risks will occur. And if we change things to the vision, these are the benefits that we will get, and that will raise the motivation. Then FS stands for identifying first steps. So as a human being, you need to have some positive reinforcement in order to keep going forward. So identify first steps that will get you closer to your vision, where you want to be, that change that you want to achieve, but easy, small first steps that will build the momentum and will get people on board. And finally, those 3 things together, dissatisfaction with the status quo, vision for how you want the thing to change and what benefits that will give you, the first 2 or 3 simple first steps to get closer, so you get up and you do something. This has to overcome whatever is the resistance to that change. You have to identify what is stopping you from making the change. Okay, so that's the change equation. And the second thing that I'm going to speak about in the following slides is so important to understand, and that is our human psychology in a nutshell, the Cartman drama triangle. In a situation where that results in a complaint arising, there's often some sort of conflict or dissatisfaction, right? Now, we take on a role in that drama triangle, and that role, we are either the victim, or we are the persecutor, or we are the rescuer. Now, it's not helpful to take on one of these roles. So whenever you are in a situation, you have to ask yourself, hang on a minute, am I playing the role of the rescuer here? Now, or am I actually playing the role of the victim? Is my mentality like, oh, this senior doctor is making a complaint against me. They don't understand, they don't know me, they haven't worked with me, but they're making this complaint. That's a victim mentality. The persecutor is you actually driving the process, saying, this person spoke to me rudely and I am very angry and they cannot speak to me that way. And I'm going to teach them that they cannot treat me like this. You are taking on the role of the persecutor there. And the rescuer is, for example, if you see a situation where there is a conflict and you say, oh, I need to go and help this victim person, you are treating them as if they don't have the resources to help themselves. You are making an assumption that you have the resources to help them, but they don't have the resources. That's you are being a rescuer. And although that doesn't sound like a bad thing, naturally, lots of us tend to try and rescue. The reason why it's not good is because you are getting into the drama with the people, and then you are less helpful to them. If you try and encourage them to resolve their own issue, that will be a better longer term outcome, longer term solution. than getting into the drama with them. So that's what the drama triangle is. I'm going to refer to this in my next slide, which is why I wanted to explain it to you. Once we understand this in our human interactions, both as professionals in the doctor-patient relationship, but also and your your relationship with your seniors and your colleagues too, and also your personal relationships at home. I'm sure that this is already sounding very familiar. If we can move away from this drama triangle and these three roles into the much more productive situation of an adult to adult conversation where you are meeting the other person as an equal and you believe in their own resourcefulness and ability to resolve the issue. You're not speaking down to them, you're not looking up to them. It's an equal, that's an adult to adult conversation. And that can often, if you step out of the drama triangle and into that situation of two adults speaking to each other with respect and dignity, then that problem can often be resolved. So if we move on to the next slide. So remember I said we're going to talk about common complaints. I'm going to share with you some scenarios, complaint stories. And when I'm sharing the scenario, think about what the takeaway message is. So from seniors, the COVID story, what was the COVID? Okay, when I was coaching one of my junior colleagues, a complaint was made against this junior colleague, a very serious complaint. As you all know, we are in the pandemic, and healthcare professionals in every country have very strict rules and regulations. If they test positive for COVID, they cannot go into the hospital. That is a serious breach of trust because you are putting patients and colleagues at risk, right? So this particular complaint was made by a senior doctor when a junior colleague had reported COVID positive, that they were COVID positive and they were off work with COVID. That junior doctor 6 days later came into the hospital because they were trying to find their senior because they needed to arrange an appointment with them, an appointment for an educational supervisor meeting. When the senior saw the senior was very shocked and said, you're supposed to be at home. You're supposed to be isolating because you're COVID positive. And the junior said, oh, don't worry, I am not breaking the law. I am here because I tested COVID negative and I have self-isolated for 6 days, which is what the regulation is. So don't worry. Now, for whatever reason, that senior colleague didn't feel satisfied. They felt that the junior had broken the rules. So they made a formal complaint. And then that went to the GMC, and then the doctor was investigated. It caused so much stress, and the doctor went off sick with work. So the takeaway message here is the consequences of poor communication. So, when that junior doctor said, don't worry, I'm not breaking the law, that didn't satisfy the senior. That conversation was not an adult to adult conversation. That was that the junior was trying to say to the senior, look, I'm not stupid, I know what the rules are and I'm not breaking the law. But the senior was still concerned. Now, a conversation with more dignity and respect may have reassured the doctor who was making the complaint. If the facts were laid out, I'm still confused about that story because you either have met the regulations or you haven't. But this is what I'm just reporting back to you from one of my confidential coaching sessions without identifying any of the people involved, to try and highlight the consequences of poor communication, ego, when ego comes into it, because this junior doctor felt that ego was hurt because the senior was questioning them. Why are you here? You're supposed to be isolating. Don't touch anything. You could be contagious. You're COVID positive. So the ego was hurt. So in this case, we need to replace the victim or the persecutor. One of them was being a persecutor. One of them was being a victim. So in this case, the senior was acting like a victim of the junior's inability to follow the regulations and saying, you're going to give me COVID. Stay away from me. Don't touch anything. Why are you in the hospital? You're putting the patients at risk. And this turned into a really, really ugly complaint that caused a lot of problems. Whereas if they had had an adult to adult conversation with some emotional intelligence, that they could have got to the bottom of that very, very quickly with some proper communication. That junior doctor could have emailed the senior first. I mean, he told me that he did email, but she didn't reply. The thing is, you can't then just be the persecutor and just go in like a bulldozer and say, well, I don't care about the consequences. So there's a good example for everybody to think about. From peers, I'm going to share another story with you. This is me, I was having a meeting with some external people from the hospital, and one of my colleagues burst into the room and said, you can't use this room. You're holding up my clinic, because that room had the keratometer in it. Now, it was very unprofessional behavior, because it caused a lot of stress and a lot of conflict. It resulted in a complaint. It resulted in a suspension of that person because they spoke in a very rude way in front of guests from outside. It was a nightmare, actually. But you know what? When you think about it, what was actually going on there? This is two consultant colleagues, myself and somebody else, and with proper communication, a little bit of calm, a situation can be resolved very nicely. There is no need for, these irritations that then turns tiny flame becomes a big fire, and everybody gets hurt and everybody gets damaged. So it's not good. But then there was something more going on there. That colleague was clearly very stressed to behave in that way. It wasn't normal. So there was something deeper going on there. From allied healthcare professionals. So once an orthoptist came into the clinic room in my clinic and said, I've been told that I can learn intravitreal injections and you have to teach me. And I said to the orthoptist, I'm very glad that you are motivated and you'd like to learn intravitreal injections, but we have to go through the procedure properly. Before you learn a surgical skill, you need to learn about the medication that you're injecting, the potential complications of the process. You need to observe, you need to understand the management, and you need to be part of the team. You can't just go straight into the theatre and start to inject people's eyes without understanding the process and the disease that you're treating, the consent. So this orthoptist took that personally. This was a process that I was describing to them, and they took that personally. So again, it's all about that drive. They felt like the victim, and they put me in the persecutor. Oh, this consultant is not willing to teach me. I am willing to teach you, but in the correct procedure. It is not personal. So that was another situation. And then, as a result of that, I felt for a good 2 years that particular orthoptist kept a grudge. They kept a grudge, and I had to work really hard to, show them that, look, the slate is clean from my side, and hopefully eventually convince them to clean the slate from their side. This is about the process. It's not a personal issue. From patients and relatives, a near miss, I'll tell you about near miss. So once the clinic was closed because we were doing an educational event, and a patient didn't know the clinic was closed, and he came to the clinic and said, I need my glaucoma drop prescription. I've come all the way from far away and I need somebody. And he was told, I'm sorry, the clinic has closed. There's no doctors here today. I walked past and I saw the patient was in distress. So I said, what can I do to help? And he said, I need my glaucoma drops. So I just took 10 minutes of my time to resolve the issue after understanding the situation. And instead of that turning into a complaint, that patient became one of my very, very special patients. Every time he came to clinic, he would make me something like made from wood, because he was a carpenter, and they were very special little wood pieces. So there's another example. Treat others the way you wish to be treated, or the way you wish your family member to be treated. So those are some examples of complaint stories, just for you all to kind of reflect on and think about the takeaway messages. So can you have the next slide, please? Thank you. So here's a question for you all listening in today's audience. When did you make a complaint? When did you make a complaint against your colleague or your, in your professional life? Have you ever made a complaint against somebody? Or has anyone made a complaint against you? Just to pause and think for a moment. Obviously, when I first became a consultant and I had my consultant interview, I was asked the question, how do you deal with conflict? And my answer back in that time, which was about 10 years ago, was I don't have any issues with conflict because I avoid conflict. And if somebody came to me with an issue, I would just say, look, let's do it your way because I don't want any conflict. Yeah, I don't. But what I found in my time is that conflict happens even if you
Recording in
try
progress.
So, for example, my junior was bringing his post-ops to my clinic. My clinic is very overbooked, busy macular degeneration clinic. There's no space for extra patients. And those patients that he was bringing was taking time away from the patients that were supposed to be seen with the official appointment. So I got upset about this. And perhaps at that time, remember I told you, I wish I knew about the drama triangle. I should have had an adult to adult conversation with my junior to explain why this was an issue. My junior couldn't understand. He said, I'm bringing my post-op patients early and I'm seeing them before the clinic. I said, no, what's happening is you're bringing them early, but they're taking longer. And then that is delaying my clinic. I say my clinic, you know, our team's clinic, the clinic that you are timetabled to be in. Now, this that was a time when I made a complaint against a junior, and I talked to him directly, and then I talked to the clinical director, and I said, I'm not happy with this. I am the consultant, and I have given an instruction to a junior, and the junior is not accepting my instruction. Now, I learned a lot from that process, as I say, understanding, but also the impact that my complaint had on that junior. That junior, to me, they seemed very overconfident and very, you know, strong. But my complaint actually affected them really badly. They became very stressed and very upset. And none of us want to upset a colleague or cause them pain or hurt. And sometimes just sitting down and having an adult to adult conversation can be much better than I became, in his eyes, the perpetrator, and he became the victim. Oh, complaints are such a difficult business. I think it's the hardest part of your professional interactions. The other time, my junior took 45 minutes to see a patient, and I wasn't happy. And I told this to the junior. That ended up in a big complaint as well. I had to speak to a junior who was leaving a busy clinic to take a break. I told you about when my colleague came in and shouted at me and said, you can't use this room. When I was head of school, I had another trainee where a complaint was made against him that he wasn't showing a lack of respect to female colleagues, and I had to investigate that. It caused a lot of time to investigate it. In my coaching sessions, I hear directly from junior doctors what issues are affecting them. And a junior doctor was told they will not progress in their training, that they had to repeat the year because they were acting above their role. Now, this junior doctor was so confused because he said, I'm so good at my job and I know how to address an emergency GI bleed. I know exactly what to do. I don't need to bother my seniors with it. What he wasn't, and he was saying, look, I'm better than all my colleagues. Like, I know more than them. And this was the problem, that he couldn't see that his seniors were worried that patient care was going to be compromised because he couldn't see that his rank was that he needed to check his management plan with his immediate senior, and that there is a hierarchy and that there is a structure. And this structure is there for patient safety. And you have to demonstrate that you are aware of this and you respect the lines of management to show that you're a safe doctor. But in his perspective, he was showing his ability, his knowledge, and his skill by getting on and doing what needed to be done without bothering his senior. Those were his words. But they then complained and stopped him from moving on because they said he is acting above his role. So that's something to think about that. And having aggressive confrontational communication techniques, that all ties in really with, you know, the communication piece and the whole drama triangle, and replacing that kind of communication with adult to adult conversations. And I'm going to speak more about this in the extreme pressure response. If we can have the next slide, please. So just a pause for reflection. Are you carrying a grudge? Remember, I told you that my colleague who wanted to learn how to, my orthoptist allied healthcare professional colleague wanted to learn how to inject intravitreal injections, and I sent him away and I said, you're not ready yet. You need to learn the basics and the fundamentals and the foundations before you go to theatre. And then that orthoptist was carrying a grudge against me. A grudge is like carrying rotten potatoes inside you. So it's not healthy, it's not good. So just think for a moment, are you carrying a grudge? And if so, what will today's learning, how can that maybe help look at your situation from a different perspective? So can we have the next slide, please? So I do a coaching workshop for healthcare professionals, which is called How to Achieve More Without Sacrificing Your Health and Your Family. And it has 5 steps. GRACE, success with grace. GRACE is an acronym. G is for, first of all, you need to get rested. You need to look after your well-being. R is for reverse engineer your goal. A is for an awareness of your limiting beliefs. And C is for communication, and also clarifying your boundaries. And E in GRACE is the extreme pressure response. I'm going to give a summary of this step 5 in my program to you now, because it relates to what we're speaking about today. So if I can have the next slide, please. Thank you. Doctors work under high pressure situations. As I said at the beginning, it doesn't matter which healthcare system you're working in, each healthcare system has its own challenges and difficulties. And the NHS is, at the moment, post-pandemic, suffering from a lack of resources in terms of human resources. We don't have enough nurses, and doctors are leaving, and the morale is very low. And I'm sure there are some positive things as well, but at the moment, the negative things are hitting the headlines a lot. So it's so important, it makes it even more relevant that we all understand how we process emotions. And Gilbert's 3 systems of emotional regulation is very important for us to understand. And I'm going to explain this in a moment. So next slide. We have 3 systems. The drive system, we are all driven as medical professionals. We had to work very hard to enter medicine, to work through university, to get our degrees, to enter ophthalmology, which is very competitive as a training program. So we are all driven. We want to pursue our goals and we are focused. We know what we need to do. We're hardworking. We don't have an issue with the drive system. The purpose of the drive system motivates us towards our goals. Okay, now, the problem with medical professionals is our soothing system is often underdeveloped. That's the green bubble, the soothing system. This is we need to develop this and keep it healthy. We need all 3 systems, the drive, soothing, and the threat system, to work in equilibrium. But often we suffer from low morale and burnout because our soothing system is underdeveloped, and our threat system kicks in. And our threat system can then be amplified. And that, remember I said a small fire, and it turns into a big fire that then burns everybody. That's when your threat system isn't regulated. So the drive system is fine when everything's going along and you're passing all your exams and you're getting all your competencies and you're getting all your opportunities. But when a threat, it kicks in, for example, a complaint, a conflict, an issue at work, negative feedback, your threat system can often be exaggerated. And if your soothing system is not developed well, then you will result in burnout, low morale. So being aware of the 3 systems and being aware of how much time you put into each one and how you balance the 3 will help your emotional regulation. So can we go into the next slide? Because I'm going to now tell you how to do that, hopefully. So before we dive into that, you need to ask yourself, what is on your very important list, your VIP list? What things in your life are on your VIP list? Because when a threat is perceived, if it doesn't threaten any of your very important things, you can ignore it, let it go, don't spend any time on it. So that's the first thing. Be aware of what is very important to you. So is your heart, keeping your heart clean, your spirituality, your religion, that's at the heart for many people. I'm not making any assumptions about anybody's spirituality. I'm just sharing with you my list. Friends and family, career, business interests, plans for the future. So that's kind of, these are the important things. As long as, if these things are threatened, I need to respond appropriately. If these things are not threatened, I don't need to give it any time. That's the first thing, stating the obvious. Next slide, please. So make your own very important list. Remember what is in your control, but also remember what is not in your control. Don't spend any energy on things that are not within your gift to influence, okay? So the things that are in your control, your thoughts, your actions, how you speak to yourself, that little voice in your own mind can often be very critical and very harsh. Change that to your own best friend. Change that voice to a compassionate voice, an encouraging voice, a critical voice, not a harsh voice. How do you spend your free time? So important, because you can't you need to spend your free time in a way that you feel rested. What you give your energy to, your life is predefined. The duration of our life, when we are going to exit this class, predetermined, right? So life is give your attention to, don't the energy to. The goals that you set are your goals, and how you handle challenge. These are not within your gift to control. Can we have the next slide, please? I think I've made my point there. So let's talk about now the solution. We're working in an extreme pressure environment. You've made it clear what your very important list is. Now a problem arises in your work situation. There's a conflict or an issue. For example, you are the consultant of your clinic and your junior doctor is bringing their post-op cataracts into the clinic, and that is delaying your patients. Your patients are then complaining that they're having to wait 45 minutes, and it's not right. The system, that's not a good system. So state the problem without any emotions. So you remember we talked about ego. I think my ego was hurt that I'm a consultant. This is my clinic. How can this junior doctor be bringing his post-op patients and taking the time away from the patients that are booked to see my team under my name as a consultant? So there was an ego issue there. Now, what I should have done was I should have separated it and taken away the emotions, the feelings, the ego, and just stated the actual problem. We can't double book slots. The doctor's solution was, I'm bringing them early. The first patient is booked at 8:30. I'm bringing my post-ops at 8. I said, but in reality, you're not here to see them at 8. They are then waiting till 20 past 8, and then you are eating in time into the clinic. So that's not working. Now that's stating the actual problem objectively, minus the emotion. Step number 2, is this on your very important list? So for me, yes, this was on my very important list because it's part of my career bit, and I want to make sure that the patients that are booked to see me or under my team, under my name as a consultant, have a very good experience. One of the top complaints that patients make is the duration that they had to wait to be seen by a doctor. So it is important to me, and therefore I'm not going to ignore it. But if this was an issue that was a side issue, then I'm just going to stop there. I'm not going to give it any more energy. Now, second question, if it is on your very important list, yes. Is it fixable? So is it something that's within your control? The slide I showed you one before. If the answer is no, i.e. it's the action of somebody else, then you've got to let it go because it's not within your control to fix. But if the answer is yes, it is fixable, then make a list of 3 things that you can do to fix it and do one of them now. And that way you've done something about it. The other 2 you can do later, but you don't need to keep thinking about it and keep it going on in your brain. Go and do something nice after that. So that's how we need to replace, when the threat system becomes overwhelming, and we replace it with emotional intelligence by using these 3 steps. So I hope that makes sense. Can we go to the next slide? Thank you. Now, just a little note on the impact of COVID with regard to complaints. Many healthcare professionals in the UK found themselves working in unfamiliar circumstances, being sent to acute wards as an ophthalmologist. Can you imagine looking after ICU patients? Like, that's a nightmare. And then with regard to complaints and the GMC investigation, so back in 2020, the professional regulators for clinical staff co-signed a statement on caring for patients in challenging circumstances. This was designed to reassure staff that allowances would be made for the pandemic if people chose to report someone over fitness to practice. What their statement was, if you find yourself working in unfamiliar roles and environments under extraordinary pressure and doing things for which you feel semi-prepared and partially supported because of the ongoing COVID-related pressures, we will take no action against you unless you are engaged in a criminal act. So that was just a little note in terms of complaints and what the regulators have said because of these completely extraordinary pressures that healthcare professionals found themselves in the pandemic. If we move on to the next slide. Thank you. Now, giving and receiving feedback is so important. Just like we have the bereavement stages, we have feedback stages. Now, listen and see if this resonates with you. When someone gives you feedback, your first response is very negative. It's like, get lost internally. You might not admit it, but inside you think, who do you think you are? Why are you telling me this? You don't know me. So it's a very negative response. It's retaliation, it's conflict, it's deflection. Oh, I only did this because of this. Normally I wouldn't do this. So it doesn't matter. It's not important. So it's a very negative response in stage 1. Stage 2, you enter this second response of actually, it's true, I'm not very good. No, I'm not good at my job. And you kind of go into this depression or embarrassment or sadness. And then stage 3, you enter this stage of, okay, I've received this feedback. What can I do to make it better? And this is the productive stage. This is the where you want to get to quickly, where your brain has become open to receiving that feedback. And your mindset is, this is an opportunity for me to grow. And it's productive. If you get stuck at stage 1 or stage 2, that's a disaster. So that's something to think about. Can we have the next slide? Giving feedback. Try compassionate candor. Now, the feedback is so important for all of us. We need it to show evidence of our progress. We need it for revalidation in the UK, for appraisal. So we are often asking for feedback because we need it for our portfolio. I'm going to tell you about asking for feedback and how to do it in a way where you'll get really good feedback in a moment. But I just want you to pause for a minute and think, the time that somebody spends giving you feedback, that they're doing you a really good deed by taking the time to do that. So always when you notice somebody doing something, don't wait for them to ask you, give them feedback and they'll appreciate it so much because you saved them a job. So, but try compassionate candor. What I mean by this is a lot of us, because we think we're being kind, we don't tell our colleagues if we notice some weakness. We keep quiet about their weakness because it doesn't feel natural to say to somebody. But let me give you an example. A doctor was giving a talk, and this was a very experienced, very intelligent doctor. But when they were giving the talk, they kept saying, oh, this is the gene that codes for this protein. So they didn't realize they were doing this. So one of their colleagues told them at the end of the talk, did you realize that you kept saying in between your sentences? And the doctor just shrugged it off as something minor. Oh yeah, I noticed, but yeah, whatever, it doesn't matter. I was delivering the important message and I'm really glad it got across. So they're not listening, they're not hearing the feedback. So this person who was giving the feedback, they personally cared about this doctor. They wanted this doctor to do well. And so that personal care, and that they gave them a direct challenge then, because they realized they weren't taking the feedback nicely. So they said, look, you need to speak to a coach, because when you keep saying in between sentences, you are the most intelligent doctor I know, but it makes you look stupid. So that is candor. That's really saying it clearly, but with compassion. You can't be rude, otherwise that's not nice. But that's how not to keep quiet about somebody's weakness, and give them feedback that's going to make them stop and listen and say, oh, okay, thank you for that. Now they're going to listen and they're going to do something about it. So you gave them the direct challenge. So that's how to give feedback, when it's appropriate. So can we have the next slide, which is about how you can all make a point of getting some feedback for yourselves. If you say to your colleague or your senior or your patient, do you have any feedback for me? They're going to say no, right? Nobody's got time to sit there and give you feedback. So if you say, do you have any feedback for me? No, you're doing fine. What you need to say is, what can I do, or what can I stop doing to make it easier to work with me? Or another way of putting it is, tell me what I'm doing wrong. And then the person that you're asking will think and give you, hopefully something that will help you to improve. Finally, when we're children and we get told off, instead of feeling, oh my God, I'm just getting told off, if we learn to listen when we are being criticized and we decide ourselves what to take and what to leave, if we do this, we're going to become stronger and better. So believing, sorry, there's a typing error there. Believing that this is an opportunity to grow versus somebody's telling you off and that's their fixed verdict. You're not very good with your hands. You're doing cataract surgery. Oh, you're not very good with your hands. Oh, that's it. I'll never be a good cataract surgeon. No. This is an opportunity to grow. You then say, tell me what I'm doing wrong. And then you take that on board, you use it, and you go past that block and you become better and stronger cataract surgeon for it. So next slide, please. Right, so how do we prevent complaints from happening? Okay, there's 4 main areas, the most common causes that complaints arise, particularly now I'm talking about the doctor-patient relationship. I've spent a long time talking about interprofessional conflict in the workplace, but now we're going to switch to the doctor-patient relationship and common causes in the NHS for complaints to arise. Number 1 is non-verbal problems. For example, eye contact, facial expression, and the paralanguage. That is the volume, the pitch, the intonation, the rhythm, the speed with which you speak. So for example, eye contact, a patient said, he didn't check on me at all. He just looked at his screen and then he just made an appointment for a CT scan. So the patient didn't feel like they were examined or really seen by the doctor, because, and now that we use technology and computers in the consultation, this is becoming more and more common a complaint. Because remember, a patient might forget what you did, but they will never forget how you made them feel. And that's a saying by Maya Angelou, a US writer. People don't forget how you made them feel. So always make people feel positive, and giving them positive eye contact, making them feel like they've been heard, they've been seen, is really important. Don't let the computer get in the way of that. Facial expression. A negative facial expression leads to doubts about a doctor's capability and a feeling of frustration and anger from the patient. For example, a patient said, when I approached him, he looked at me as if he was not happy. What kind of doctor is this? I hope he can change his attitude. So remember, that might have been your 30th patient that you've seen. You're tired, you haven't had any lunch, you're hungry, you're fed up, but the patient you're seeing you're seeing him for the first time. So if you don't greet them with a smile, they don't feel welcomed. So that facial expression is very important. And another patient said, I understand that doctors are very busy in their daily work, but it's always a different experience for each and every patient. The least that the doctor can do is not express their wariness to their patient. So a little point about the language. Although I spoke to her nicely, she responded to me with an inhospitable attitude. She advised me to keep it clean in a very tired tone that obviously showed she was bored with advising the same words to many patients. So that's a comment that was made. Can we have the next slide, please? And we'll talk about the second most common cause for complaints and how to avoid it. Those are verbal issues. Now, it's the interaction that the doctor and the patient have. It's so important to really listen when your patient is speaking to you or the carer is speaking to you. So don't be like writing notes and half listening, because that's the opposite of active listening. Patients feel that, and it's a common cause of patient complaints. This is what a patient said. When we asked how the patient was doing, it was the patient's carer. So the carer said, how's the patient doing? The doctor only questioned if we were unaware of the patient's history. So basically, the doctor wasn't interested in answering their question. They were just asking their own questions. The patient's relatives reported that the doctor failed to answer their questions. Instead of addressing their own concerns, the doctors proceeded to ask the questions that were important to them. Here's another comment by a patient. She, i.e. the doctor, talked without any notable pause to allow questioning. She was not interested to focus on listening or pay close attention to the questions that I asked. And when I was finally able to ask, she was always cutting me off while I was in the middle of asking or explaining my concerns. So she didn't actually even address my concerns. So that patient will leave very down and very upset, angry and frustrated, and that will result in a patient complaint. So just giving the patient time and actively listening to their concern and addressing their concerns by using the same words that they used, by summarizing your understanding. Okay, you've explained to me your symptoms. Let me just check that I understood you correctly. You have got reduced vision that came on gradually over the last 3 weeks. And the patient's like, yes, that's right. The doctor understands me. That's active listening. Okay, next slide, please. What about what you say? Okay, the quality and quantity of the information. A common cause of complaints is poor quality and quantity. So a patient said, I was very upset and disappointed. The doctor didn't explain the MRI results in detail. I had to keep probing. I've seen many better doctors before. She didn't seem to know her job at all. A doctor proceeded to make arrangements for a patient to undergo surgery without even providing them with the information. She needs to learn not to barge in on an oblivious patient and deliver the news of her actions she'd already taken. She booked the appointment for the surgery before even telling me what my test results were, what the findings were, what it meant. And most importantly, she didn't go through the available options. She just booked the surgery for me. So that content of the consultation is a very common cause for complaints. So be aware. And finally, if we can have the last slide, the next one. Attitude. When doctors fail to introduce themselves to patients, there's a big campaign in the NHS the campaign is called Hello, My Name Is. And this was after a patient observed, she herself was a nurse and she was in for chemotherapy because she'd got cancer. And she was shocked at being a patient because she said, people would just come, healthcare professionals, and just talk at me. And I didn't know who they were. So she started the campaign, Hello, my name is, and this is my role. I'm here to do this for you. So also, doctors need to seek permission from the patients for medical students to be involved in their care. And when patients also complain that desirable attitudes were only demonstrated in the presence of a senior clinician. So these are things to be aware of. Dr. X, who was consulting my father, was very rude, very unhappy, very impatient, and lacked patient care. They showed a bad attitude, and they only showed professionalism when their senior consultant arrived. So that's not good. Okay, next slide. That concludes the 4 common causes for patient complaints and what to do to avoid them. And then just to reiterate, if you want to see change happen, first, raise awareness of why you are dissatisfied with the current status quo. What harm is it doing for you? And what harm will it do if you don't make a change? Number 2, have a vision of how your situation is best resolved. What will that look like? What will it feel like? How will you know when you get there? And then identify first steps that you can implement fairly soon to get the momentum going, to get you closer to your goal. And all of these need to exceed the resistance to that change. What is currently getting in the way of making that change? How can you overcome these? And then just to remind you all of the drama triangle, don't be the persecutor, don't be the rescuer, don't be the victim. Change those conversations that you're having with others and you're having with yourself to adult conversations where you believe in your own resourcefulness and your own capability to do the right thing at the right time for the right person, but also in the person who you are dealing with. Believe in their resourcefulness and their capability authentically, and that will, develop the trust when you put yourself in their shoes, the empathy, the authenticity, and the logic. These 3 things will develop the trust that will then help you move through and reduce conflict. So if we could have and hopefully reduce the number of patient complaints or colleague-related complaints. So the next slide, I think, is just to say that's the end. Yeah, here are some useful resources if you're interested in reading more about this topic, and that's all. So everybody's welcome to a copy of the slides if they wish. Dr. Adnan can send them to you.
Dr. Ijaz?
Yeah.
So what do you?
I mean, obviously these situations are unique to countries like UK, and maybe if somebody is going to Ireland, or even I think in Middle Eastern countries, they have their complaint system and look at different aspects. Thing is, how you tackle these situations in person, in the clinical situation, and these rules can be applied to daily life matters. If there's any conflict, if there's any complaint, somebody is not comfortable with your work behavior, or you are not happy, so it's not that you just go straight forward and try to confront. So this is the whole exercise. Just be comfortable, try to make sure you understand what is asked for. Problem is because we are not used to these systems. It takes time. And unfortunately, a doctor in UK especially, he learns more or she learns more when they have gone through a complaint process, or maybe they have been referred. Because there are only 2 types of doctors, one who have been referred to GMC, others who are going to be referred anytime. So it happens because it's a frightening. One feels, okay, are we going to lose our job or our career? What we will do? But luckily, support is available, and situations which have been described, they're personal ones from Dr. Khan. But I believe messages can be taken forward and applied to any situation. Thank you.
Thank you so much.